All right, let's talk about Code Blue. Code Blue, what's a nurse to do? And I have to apologize, I'm not using my regular mic. As I told you guys, I'm in the Philippines, so my connection may not be the best, and then the mic is not necessarily the best because I'm using my laptop. So please bear with me. Hopefully, this still helps with your exam preparation. These are the objectives. So discuss cardiac emergency to include the use of the crash cart and the importance of BLS, and then identify the Code Blue team. Here's some statistics pertaining Code Blue. Well, 100% of people on this earth die of cardiopulmonary arrest, right? Whether it's a primary problem or a secondary problem, but 100% of people on this earth, they die because of cardiopulmonary arrest. And approximately 6.8% of people who code survive to hospital discharge with CPR alone. So that tells you the importance of having BLS or CPR. Now, the survival percentage increases to 50 to 60% when early defibrillation and ACLS measures are introduced. So I highly encourage you that down the road, once you have your license, to get your ACLS. Now, there's really nothing wrong with BLS. I think that's really great to have, but again, ACLS will give them a better chance of surviving a code blue or cardiopulmonary arrest. Now, 99% of hospitals use code blue to signify sudden cardiopulmonary arrest. I haven't really worked at any hospital where they've used a different code. So code blue usually pertains to cardiopulmonary arrest. Some hospitals, though, use a different color code for pediatric arrest, but generally speaking, when we're talking about code blue is cardiopulmonary arrest. So just so you know, oops, let me put it back. There you go. Just so you know. All right, as much as Code Blue can get a little bit exciting in a way, right? Because adrenaline is pumping, you get to do CPR. That being said, we want to try our best to prevent codes from happening, and hence the birth of rapid response team or the rapid response. So this is really a way to hopefully intervene before the code even happens. So, rapid response team. 50% of patients who code exhibit warning signs up to 6 hours prior to arrest. And so, this is really where your nursing assessment skills and clinical judgment comes into play. You know your patient, and sometimes even if the numbers are right, if you look at the labs, you look at the vital signs, they look good, but you have this feeling just from assessing your patient, they just don't look good, right? There's really nothing wrong when you call a rapid response. Again, this will just allow another set of eyes and ears to assess your patient and to hopefully prevent a code from happening. Now, let me go back. I believe, if I'm not mistaken, I mean, my memory is not the greatest right now, right? But if I'm not mistaken, I've never really had my own patient code on me. And so I think that's a really great thing. I mean, I mean, it's exciting. I don't mind doing CPR, right? But I think the reason for that is I always, whenever I see something wrong, something concerning, I usually almost immediately communicate it to the provider. And I am one of those nurses who would call a rapid response whenever I'm concerned about a patient. So an example of that is, gosh, a while back, I had this patient, I was still working in tele, and I had this patient that just didn't look good. So this patient wasn't looking good. I mean, her vital signs were fine, but I noticed that she was breathing a little bit, she was struggling to breathe a little bit more than usual. And so I called a rapid response, and I remember my charge nurse actually came to me and got mad at me. This is normal for this patient. That's what she told me. I remember she was upset because it was just extra paperwork. I was calling the rest of the team, right? I was using resources, right? And so my charge nurse at the time, she canceled the rapid response and said, no, this patient has been like this. There's really nothing wrong with this patient. And everyone else left. Guess what? At the end of my shift, right, I clocked out, I gave report, I told the following nurse my concerns, and then I kind of just, gave report, what's going on with the patient, what was my concern. Anyway, so I was hoping that my charge nurse was right. I went home, right, I rested, went to sleep. Came back to work. Guess what? When I came back to work, my patient was gone from the room. I asked about what happened to that patient. That patient actually ended up coding and went and afterwards was transferred to ICU. So anyhow, that's really a really good example of nurses having this gut feeling, right? We know our patients, and even like the patients themselves, sometimes they can tell you like that they don't feel good, that something is off. You need to listen to them and assess them, right? You can't just always base it on the monitor, on the vital signs, because sometimes numbers can be deceiving. And then again, the body can compensate to show you those numbers, right? The ranges that we want to see. But at the end of the day, the body will also get tired. So again, please utilize the rapid response team, and this will prevent you from coding your patient. And again, I'm really proud to say that as far as I could remember, I've never had my own patient code on me. And the only patients that I've had that I guess died were patients who were on comfort care. So, well, I guess under my watch. I mean, I've had patients die before that I've cared for, but not during my watch. And I've been a nurse for forever, right? I've been a nurse for how many years now? 13 years at least. Anyhow, going back to the rapid response. So let's talk about who is in the rapid response team. So the RRT or rapid response team usually consists of an ICU nurse, typically the charge nurse or the resource nurse, a respiratory therapist, and occasionally in some hospitals, the doctor or provider would be at the bedside too. But where I used to work, usually they would respond as needed. The rapid response lead actually calls the doctor if they need orders, but usually there are sets of protocols that's already in place. In addition to that, the bedside nurse should be part of the rapid response team, because the rapid response nurse, I mean, the bedside nurse will be able to provide information pertaining to the patient and kind of give them a background of what had happened and what's going on with the patient. Now, the RT should be at the bedside within minutes to assess the patient. Occasionally, X-rays and labs are also part of the RRT. Whenever an RRT happens, um, X-ray and labs either it depends on how busy they are and depends on the facilities policies. But usually either they call and ask, do you need an X-ray or a lab? Or sometimes they just respond and they're just there by the door or at the bedside, just ready to basically take some X-rays, take some lab if needed. All right, when do we call a rapid response? So these are criteria for calling RRT. Now, this is not going to be the same for every hospital, but this is generally speaking, these are things that we look at that triggers us to call a rapid response. Um, for those of you who are in Mercy, rapid response is really equivalent to ABC, a code ABC. Anyway, going back, so if there's any change in the heart rate of the patient, so if the heart rate is less than 40 or greater than 130, that can be a reason for a rapid response. Any change in systolic blood pressure, less than 90 or greater than 200. Now, even if it's within these limits, maybe the heart rate is between 40 to 130, but there's a significant drop or change, maybe maybe 10 to 20, that can also be a reason to call a rapid response. Same thing with your systolic blood pressure. Again, even if your systolic blood pressure is between 90 to 200, if you see that your patient usually is in the 140s and next thing you know they're in the 110s, I mean, that would have been a perfect blood pressure ideally, right, for everyone. But that's a significant drop for the patient, so that should be a concern. That being said, it doesn't mean that we call a rapid response the first time that the patient has that type of reading. Sometimes what we have to do is evaluate what could have caused it, right? And maybe recheck it again. Now, if it consistently stays that way, then we need to call rapid. Again, assess your patient first. Don't always just go based off the number. Now, if there's also a change in respiratory rate, if the respiratory rate is less than 8, or if it's greater than 28, or if there's any threat to the airway or change in oxygen saturation, we may need to call a rapid response. Another one would be a change in mental status, maybe a significant decrease of urine output of less than 50 ml in a 4-hour period, and any suspected sepsis or confirmed sepsis. Especially now, most of the hospitals, as far as I know, whenever you have a sepsis alert, that actually triggers a rapid response. Now, suspected MI, don't get me wrong though, don't just call don't just call a STEMI on your own after an EKG. I made a mistake a while back, a couple of years ago actually. I was already a shift manager, it was night shift. We had a patient, I think, having chest pain, and I was working at a cardiac unit at the time. And so anyway, so this patient was having chest pain. We did an EKG. There were ST segment elevation, and since I was concerned, I didn't know. I think I was newer at that position. I didn't know what I could and could not do. And so what I did is, after I saw that there was an ST elevation, I went ahead and called a STEMI alert. And so that activated everyone from the cath lab, that page, like the doctor, that page, everyone in the team, right? They had to be there at a certain period, within a certain period of time. Well, anyway, needless to say, somebody got mad at me just because I guess they said that it wasn't new or something like that. That ST elevation was not new, and that they could do the heart cath sometime. I don't know, that in the morning. So anyway, don't just call a STEMI. Start first with a rapid response. So that should have been what I should have done. Call a rapid response and then have the patient evaluate from there. So that was a mistake. Please don't do that. Anyway, so again, call a rapid response for suspected MI. Also, if you as a nurse or the patient themselves or the family members are concerned, again, sometimes it's just the gut feeling. We just look at them and we know that something is wrong. And again, some patients know when something is going to happen to them. So again, listen to your patient, listen to your gut feeling, listen to the family. And there's really nothing wrong with calling a rapid response and really finding out, okay, there's nothing wrong. At least you know that the patient is fine, rather than assuming that the patient is fine and you end up with a code. Patient safety is your priority. It doesn't matter if somebody tells you, oh, you're wasting time whatsoever, right? At the end of the day, right, you have to care for the patient. So if you're concerned, call the rapid, and that's okay. And another one that I wanted to add is suspected CVA. So for some hospitals, if there's any change in mental status, you have to activate the rapid response. That way, they can call the necessary personnel for that, and so that we can coordinate a faster CT. Again, if there's a suspicion for CVA. All right, do not resuscitate. So is a patient full code or there's no code? So it is very important to check your chart for documentation of the code orders. Because again, that will tell you what to do for this patient. Now, generally speaking, if there is no order, we will assume that everyone is a full code until we get documentation that they are not. So again, that documentation needs to be in the chart, right? It needs to be a doctor's order. There should have been a discussion with patient and the family. The chart and the MAR should be labeled. And again, it is very important to follow this. This is an order. We can't deviate from it. So if the chart says full code, that's what we're going to do regardless of how we feel about it. Now, there are exemptions, and we're going to talk about it in a little bit. Okay, so first, let's say we're coding a patient and maybe their full code, right? That's what the patient wanted, their full code, and they verbally said it. Now we've done everything, and then family members are at the bedside, and they said, you know what, we changed our mind. Grandma is suffering, please let her go. Now, usually that's okay if there is no documentation, right? Now, if you have documentation such as your post, which we're going to talk about later, or if they have an advance directive, we need to follow the legal documentation. So if there's legal documentation of the patient's wishes, we have to follow that regardless of what the family says. Now, I know it is hard, especially when the patient can no longer decide for themselves. So that's why it is very important to have that type of conversation with family members before things like this happens to begin with. And so again, if they don't have any legal documentation of their wishes, if they want to be resuscitated or not, then the family can actually take over and make the decisions when they can't do it themselves anymore. right? But if there are legal documentations, we have to follow that no matter what. All right, so down the road, we're going to talk about pulse and then advanced directive. Um, Let me see. I can't really remember if I have a slide on advanced directive. Anyway, just in case I don't have it, I'm just going to talk about it briefly. So advanced directive is really considered a living will. So what do you want to be done for you when you cannot make those decisions for yourself? And so it talks about, it can talk about code status. It can talk about life prolonging measures. It can talk about the medication to feeding, and at the same time, it can also have a designated person to make those decisions for you. So advanced directive can be very extensive or simple depending on the wishes of the patient, but this is basically a living will. So this is when you're still alive, but you just can't make those decisions for yourself, and this pertains to healthcare. This doesn't pertain to property. What we're talking about here is what's going to affect our care to the patient. So anyway, so that's an advanced directive. All right, let's talk about PULSE. PULSE is basically a physician order for life-sustaining treatment. So PULSE is a legal document that will tell us providers or tell whoever, because this can actually be sent to different facilities where the patient is going to be cared for. So this is an example of PULSE. This is not completed, but it tells you, what do they want to do pertaining to CPR? Do they want us to attempt CPR, or are they a DNR, allowing natural death? It also specifies medical intervention. So do they want full treatment? Do they want to pick and choose, right? Selective? Do they just want IV fluids? Do they want to be intubated? Don't want to be intubated, right? This is very specific. Or request transfer to hospital only. In addition, there's also this comfort focused treatment. So they can be as specific as they want to be, and then there could be additional orders. There's also part of this where it talks about nutrition. So would they want long-term, short-term trial, or no artificial nutrition at all, and some additional orders. And then it has to be signed by the provider. Again, this is a legal document, so we have to follow this. So this is basically a one-page front and back document. Usually it's in a bright pink paper, but it can also just be a regular paper and just print it out. It is now, I guess it's a good practice to have this established before a patient's health status starts to decline. When I used to practice as a nurse practitioner, this was part of my annual physical. So whenever my patients will come in for annual physical, especially the older people, we would just mention it. Would you want to fill up? Would you want this to be done for you, right? And usually, if they're not ready to make a decision, I just give them a copy and just allow them to think about it, and then, make those decisions, talk to whoever they need to talk to, and then whenever they are ready to maybe complete it, then they can set up an appointment and we can go over it, and then we'll sign it. All right, so this is the back page of the PULSE order. All right, now let's talk about calling a code blue. So basically, right, if you go in the room, right, you look at the patient and they're unresponsive, right? Basically start with your typical BLS, right? Are they responsive? Do they have a pulse? Are they breathing, right? If they're not either not breathing or don't have a pulse, call a code, right? And so again, check for cardiac or pulmonary arrest, call out for help, and then push the code blue button at the head of the bed. Usually, it depends on where you're at. I know at KM, I guess the code blue button is not working, so you may have to just yell it or dial a number depending on your location or facility. So again, certain facilities, you just pick up the phone and dial a number, and then it will allow you to call a code. Sometimes you will have to identify what it is. Just say, code blue, patient was found down, and then sometimes it will just give you a prompt on what buttons to press, depending on what kind of code do you need to be called. And so in addition to that, make sure that you provide them with the location and the room number. So when there's a code, please use, well, if it's working, please use the timer or clock that's located in the patient room. Anyway, so this is a crash cart. We'll go over the crash cart, and then this is just a VFib EKG strip. As I told you guys in class, this is from a project that I've done for my BSN, and I thought this was a really fun project to have, just having mock code blues. I thought that it was a great learning experience for everyone. You already called for help, right? While waiting for the team to arrive, hopefully you already started doing CPR. Again, CPR, start doing CPR, take in consideration the circulation, airway breathing, defibrillation, right? Especially if there's AED, if you are not ACLS certified. Also, so after that, continue doing CPR until they arrive. Make sure that somebody has already obtained the crash cart. Please do not leave the patient to get the crash cart on the other side of the unit. Right? Stay with your patient, continue to do CPR, and usually once they hear the code, somebody else will bring the crash cart. Now, once, while waiting, hopefully other people will respond. And so the goal is to remove extra furniture and extra stuff to allow for more space for the staff and the crash cart. And so usually the staff or resource nurse or sometimes a house supervisor will page the chaplain for family support. We'll call the attending physician. And then let's make sure that there's a computer in the room just in case we need to look at labs, we need to put in orders, and so on. So when the code team arrives, please continue doing CPR until everyone is set, right? Even if they're already there. And then when someone is ready to take over, that's the time that you stop and basically switch, right? Make sure that you're doing it accordingly so you don't have a prolonged period of time when you are not doing CPR. So this is an example of that. And so anyway, if you are the assigned nurse, do not leave the room. Again, they're going to need you. They're going to be asking the information. What happened? What was going on with the patient? What was the reason for admission? What were the latest labs, your assessment findings, and so on? If you leave the bedside, it's really going to be hard for them to really treat the patient, because in addition to all of this, right, as the code is happening, they're also trying to figure out what could have caused the code from happening. So they're basically checking their H's and T's, right? And so please do not leave the room. Stay in order to provide information and sometimes to assist. I know it can be scary, but please do not leave the room when the code team arrives. All right, so the code team and their roles. So this is just a general list of people that are going to be in the code team and their typical roles. So you have your hospitalist or ER doctor. Once they arrive, they usually take on the team lead position, and they're also responsible for intubation if the RT is not going to intubate. So they give orders as we go. Now the ICU nurse or critical care nurse, they usually give meds. Sometimes they're the ones leading until the physician arrives. And then you have your supervisor or staff nurse. One of them would document. Usually, as soon as the code starts, a team lead will assign a recorder or somebody who's going to document the code. Now, you also have your respiratory therapist. So again, like I told you earlier, they may intubate the patient if the doctor is not going to do that, or if they get there before and the patient needs to be intubated. But also they're mainly responsible for the airway. They make sure that they are primarily bagging the patient. Although other people can also bag the patient, but since they're there, usually they take on that role. They assist with the respirations. Anyhow, lab are usually there also to draw labs for ABGs, BMPs, CBCs. So we usually, whenever there's a code and the lab is there, we usually ask them to draw a rainbow. So basically draw every lab possible. So there's going to be different colors of tubes. That's why we call it a rainbow, just to see what's going on with your patient. Now, the CNA or nurse assistant or PCT can also do CPR. They can bring the crash cart and chart. Again, this is not the code documentation, but basically chart within their scope, and then help with the other patients. Occasionally, especially during the day, if there's a chaplain available, they may answer to the code, and they usually assist, comfort the family, and just make sure that the family is okay. Now, security also answers just to make sure everyone's safe. And as you know, sometimes during these stressful situations, things get out of control, emotions can take over. Some patients' family, they get angry, they get a little too emotional, and they can get disruptive. And so that's why security often answers. Now, as a student, you're just able to basically do CPR, right? There's no problem with that. You should have your BLS, so you can continue doing CPR now, or you can also just observe. Please, because this happened to my students in the past, please do not take the role of a recorder or the person documenting. I guess, I don't know, there was a code a while back, and my students, one of my students, they just gave her the documentation sheet, the code blue documentation sheet, and they basically told her to document. And in the middle of the code, when I looked around, because I was coordinating chest compression, just making sure that my students were, switching and all that stuff. And I see one of my students, she had the clipboard, and I was like, oh my gosh, you're documenting. And so what ended up happening, I had to assist her. And so the thing with the person recording is also the person keeping track of the time. And so you have to really know your ACLS. So I mean, she received a lot of assistance. I had to co-sign that for her, but because there should be an RN recording. Anyhow, needless to say, the nurses who were there got in trouble because one of them should have documented. They shouldn't have given it to the student. And I had to talk to my students and said, don't feel pressured to document. That's not your role. It doesn't matter if they give you the documentation sheet. Anyhow, so please participate in the code, but don't be the recorder. You can do CPR, you can observe. Now, if I'm there, if no one else could push the medication and you're closest to the IV site, as long as I'm there, then I will direct you and help you with that IV push. But ideally, typically, the students will just participate in doing CPR and observe. All right, what happens after the code? And so, regardless whether the patient survives or not, gets transferred to the ICU, there are some steps that we still have to do. We still have responsibilities even after a code. So after a code, the patient's nurse gives report to the receiving nurse if they have to be transferred to the ICU. We have to care for the family and keep them informed, even during the code, actually. Code summary will be printed, or the documentation should be available. Make sure that the doctor actually signed the code blue documentation sheet. The EKG strip should be charted or filed away in the chart. Again, make sure that the code sheet is completed and signed by the physician and the nurse. We need to check for the accuracy of, the meds, the time that was given. It needs to match. The last thing we want is that if there's an audit and it looks like we didn't follow ACLS, or we didn't follow what we were supposed to do for this patient. And that's not going to look good, especially if the outcome was not good. So please, once you become a nurse, make sure that if you are the recorder, you are recording it straight, not writing it on a piece of paper and then losing it and then just, unable to follow the actual sequence of what had happened. In addition to that, most of the code sheets will have a second page or a page in the back where there is a code evaluation. So this should be completed. It basically asks, like, what are if there are, how did the code happen? Was the patient on tele? Is there any missing materials? Like, how was, kind of like a debriefing, sort of like what was good, what was not good, what was missing, and so on. And kind of that will help us evaluate, how can we make perform during a code blue better, right? And that will help with the outcome as well. Anyhow, a copy of the code sheet goes to the chart, and another copy goes to risk management. In addition to that, we need to make sure that we're exchanging the cart, because you never know. There are some shifts when you have multiple codes, and so if you don't replace it, right, you may run into some problems if there's another code, because then you won't have enough supply. So please make sure that's also being replaced. And then again, documentation. In addition to the code sheet, you still have to document in your EMR, make sure that everything is matching, right? Vital signs, maybe if you check some blood sugar and so on. So please, documentation should be pretty much consistent. All right, so documentation, what should be documented? Again, patient assessment, right? Before the code happened, that's very important. And then when the patient was found, EKG strip before and during, right? So whatever was recorded. Also the notification of the MD. So if they were notified, if there were any orders received, make sure that it's on the computer as well. And include the treatments initiated, the patient response, post-treatment, and the rhythm strip. Now, if the patient is transferred, make sure you note the mode of transportation, the transfer note, and then the receiving unit bed and then the receiving nurse. So this should be included in your documentation. So this is an example of a completed cardiopulmonary arrest record or the code sheet. This is just an example. I made this up a long time ago, so you can see what year was this, 2014. Anyway, so this is how it usually looks like. There may have been some changes if it's still in the same hospital, but it can look similar. They're not all exactly the same, but as you can see, there is the code status, the date, when the code started, CPR, who initiated CPR, what was the initial rhythm, present any respiratory status, well, what's the respiratory status, here's the defibrillation, what else? Epi was given at this time, right? What dose? Same thing with amio. Amio was given. What dose? IV drips. Where was the site? And then here, the time that the doctor was notified, the ER physician's name, when they arrived, also when the patient, the RT arrived, as well as the intubation, how it was verified, and who inserted the ET tube, and then at what time. And then on this side right here, right, there's the rhythm, and then the times over here with the rhythm and what was done, right? What's the rate, or if there's any pulse, right? If there's no pulse, then indicate so, because that would have been considered a PEA. And then additional notes. So over here, example is at 8:56, there was no the leads weren't placed yet, so there's no rate, there's no pulse. The patient was found unresponsive, no pulse, no breathing, code blue was called, CPR initiated. Now, as you can see here, let's see, at 9:03, patient was on VFib, there's no rate, the patient was pulseless, and intubation was started, and CPR was ongoing. Over here, it says that at 9:05, patient was back to normal sinus rhythm. They weren't able to identify the rate, but then there was a pulse, so CPR was stopped, and then the rhythm was checked. And then here, patient still on sinus rhythm. There was a pulse. The blood pressure was 88/40. 9:07, normal sinus rhythm. The rate, I don't know what happened here, to be honest. How come they couldn't figure out the rate? I don't know. I think I used a real example of a code that had happened, and I just rewrote it just to prevent any, HIPAA violation. Anyway, so then this is when the code blue finished. As you can see here, there's the drips that was ongoing, and then what was the outcome. So the patient survived, went to ICU, and then recorded by me, right? And signed. This was my maiden name. Anyway, and then the physician should be signing it. So what's your role as a student during a code situation? So, well, as a student, you're still able to assess, especially if it's your patient, so you can help with the assessment and reassessment. Now, if you're there when a code happens, right, when you find a patient unresponsive, then you have to notify the nurse immediately of any changes in the patient status. Again, obviously, if it's a code situation, you don't necessarily have to specifically find that nurse. You have to ask for help immediately and call a code blue. Now, you can also bring the crash cart to the room, and you can start performing CPR. sometimes, especially if the code team arrive, then you can be an observer if they don't need you to participate, but I would rather have you guys participate. So I say just form a line behind the person, if there's space, of course, behind the person compressing. That way you can take turns, because really CPR is more effective if you're taking turn. That way the person who's doing it doesn't get too fatigued, because again, you want to make sure that the quality, the depth and the rate of compression stays within certain limits, because again, you want to increase the chances of this patient to returning to what do you call this, to their, well, you want to make sure that there's a better outcome for this patient. Anyhow, you can also help with the patient's family, especially if you've already established a relationship with them, just comforting them, maybe offer them a seat, because one thing that we don't want to do is maybe the patient's family member gets too emotional, and maybe some patients' family members can faint. So I would say have them sit in a corner. They can watch. Usually, in some hospitals they discourage watching during a code, but there's evidences out there that actually encourages patients' family members to participate during a code, because it gives them a different perspective on what the patient goes through during a code, and actually, so for some people, it gives them a reassurance that we did everything for their loved ones. So anyway, you can help comfort the family, offer them a seat, and all that stuff. All right. And this is a crash cart. So usually, and the arrangement of things is not going to be the same for every facility. This is just an example of a crash cart. Usually on top, you have your defibrillator. Sometimes you'll have the intubation equipment on top. Over here in this little drawer, you can open this. Usually there are some meds and flushes. So epi is usually on the first drawer. O2 tank usually is on the side, and then suction and ambu bag is usually hang here. This is a suction device over here. And then the drawers and side drawers will have meds, IV equipments, respiratory supplies, some trays, gloves, sutures, flashlight, and so on. So again, it's not always supplied the same way, but for the most part, the basics would be there. Generally speaking, they should have all of this. These are examples of medications that are on a crash cart. So again, oxygen's usually on the side. You have epi, amiodarone, atropine, adenosine, diltiazem, digoxin, calcium, usually calcium gluconate, lidocaine, magnesium sulfate, dobutamine, dopamine, Narcan, and sodium bicarb. So this is an example of how it may look like depending on what drugs are available.